Hi, everyone. My name is Paxton Bach. It is my pleasure to be here today to talk to you a little bit about extended-release buprenorphine injections. This is a talk I've given at ECHO in the past, and a product that I'm really excited by. So I'm happy to lead the didactic portion of the presentation today, and then we'll get into a case. To be clear, when we're talking about buprenorphine extended-release injection, in Canada, currently the only injectable formulation of extended-release buprenorphine is the Sublocade product made by Indivior. So when we're talking about the specifics of this, we are referring to that product, but we will stick with generic names to avoid any industry bias. And just know that there are other extended-release formulations out there. They're just not available in Canada at the moment. Next slide, Lindsay. So just an acknowledgement with regards to these sessions that this material is made possible through a contribution from Health Canada, but the views expressed here do not necessarily represent the views of Health Canada. And my disclosures, I have no financial relationships with industry to disclose. I do receive research funding from Michael Smith Foundation for Health Research and the CIHR for unrelated topics. And I'm receiving, the presenters receive an honorarium for these sessions. As far as commercial support for ECHO as a whole goes, the opioid use disorder at BC ECHO program receives financial support from Health Canada, and our alcohol use disorder series receives funding from the government of BC and Doctors of BC as well as some in-kind support from the BCCSU. And all the content for today's session has been reviewed for potential bias, has been validated by members of an independent scientific planning committee, and has been accrued, as mentioned, has been approved for CME credits. So the learning objectives for today's session is first off to describe the availability and current coverage for extended release buprenorphine injections in the province of BC. We're going to talk a little bit about when to select extended release buprenorphine as a pharmacologic intervention, given a patient's presentation and their particular needs and circumstances, and then specifically and practically how to go about administering the buprenorphine injection, including both initiation as well as discontinuation when applicable. So buprenorphine extended release, this is an injectable formulation of buprenorphine, which is injected subcutaneously into the abdomen once monthly. It's been the notice of compliance for this particular product was issued by Health Canada in November of 2018, and in June of 2019, it was recommended for the treatment of moderate to severe, or for coverage for the treatment of moderate to severe opioid use disorder in adults. So it's been available in British Columbia through special authority since April of last year. So coming up on a year now of experience with this product. I won't spend a lot of time dwelling on the evidence supporting the product, but I'm happy to talk about this at length if anyone wants to offline. The evidence primarily comes from a series of studies that were put forward by Indivior, so I guess that's worth noting. The primary study which led to the approval of this product in BC was a 2019 RCT, which found that extended-release buprenorphine injections were associated with significantly higher retention as well as absent percentages compared to placebo. I will note that it is compared to a placebo injection, not the sublingual tablet. There has not been a study to date comparing the injectable formulation to sublingual, so an important caveat to keep in mind. A follow-up study from that initial RCT, a longitudinal study published in 2020, which rolled over patients from that RCT as well as an additional cohort, found that 75% of those who were retained in treatment for 12 months were abstinent, compared to just 24% of those who remained in treatment for just 0 to 2 months. And an additional follow-up study, an open label follow-up study with retention rates of just over 50% at 12 months, had 85% of candidates who were retained on this medication reporting either they were satisfied, very satisfied, or extremely satisfied with the treatment. So in those who have been retained on it, a high level of satisfaction with the injectable formulation. The indications for the product, as per the product monograph, are adults with moderate to severe opioid use disorder, similar to those who are candidates for maintenance with buprenorphine. In order to access the injectable formulation, a patient must be stabilized on sublingual buprenorphine for at least 7 days before starting the injection, and they must be stabilized on a dose between 8 to 24 milligrams. And we'll circle back to this because this is important. As far as the actual initiation process goes itself, again, we will talk a little bit about how to obtain special authority and obtain the medication. But once you have it in hand, the actual process of administering it is quite straightforward. So you have a patient who's stable on sublingual buprenorphine, who can take their buprenorphine as they normally would in the morning, if that is when they take it, can come into clinic, and you will receive from the pharmacy a pre-packaged syringe with a sterile liquid inside. The color varies from quite clear to slightly yellowish, and it's quite viscous, and it comes in a pre-filled syringe with a needle included. It comes with a 19 gauge 5/8-inch needle. The 300 milligram dose, which as we'll get into is the induction dose, is 1.5 mils of this viscous liquid. It's called an atrogel is the proprietary name for the compound. The maintenance dose of 100 milligrams comes in 0.5 milliliters of liquid, again in a pre-filled syringe. So when a patient comes in for induction in your clinic, the recommended induction dose is 300 milligrams, or the 1.5 ml syringe, once every 28 days, once monthly, for 2 doses, at which point the recommendation is to step down to 100 milligram as your maintenance dose on an ongoing basis. And that is, as mentioned, injected subcutaneously in the abdomen, rotating through the 4 quadrants over time. The details on that step down to 100 milligrams come from that 2019 trial, RCT, that I mentioned. So in that trial, where they use 300 milligram doses as the induction dose and then step down to 100 milligrams, that was found to be equally as effective as maintaining people at 300 milligrams throughout. But those who were maintained on the 300 milligram dose throughout, while not having any increased efficacy in that trial, it did come with a slightly increased incidence of adverse events, which has led to the recommendation to drop down to 100 milligrams as your maintenance dose after 2 injections. You can increase that back to 300 milligrams if it's felt to be clinically indicated. If you feel like 100 milligrams is not sufficient, you can always increase to 300 milligrams. Or truthfully, there are patients where we just maintain them at 300 milligrams and we don't even make that drop down to 100 milligrams. One of the keys here, and it's not a paper that I believe is published yet, but it should be coming, and it has been presented at some conferences, is that in a subgroup analysis of that initial trial, so in a propensity match subgroup analysis, patients with a history of injection opioid use actually did fare better when they were maintained at 300 milligrams and not decreased to the 100 milligram dose. So there are a number of considerations when you're deciding whether to stop to drop down to 100, whether to stay at 300, or whether to increase back to 300 once somebody has already stepped down to 100. But suffice to say that in people with a history of injection drug use, you may be inclined to keep them at 300 throughout, as you do achieve higher serum levels of buprenorphine. The product itself, as I mentioned, the storage administration is very straightforward. It's stored at the pharmacy in a refrigerator between 2 to 8 degrees Celsius. It must be removed from the refrigerator at least 15 minutes prior to administration and allowed to come up to room temperature. And once it's outside of the refrigerator, it can actually be, as long as it's in original packaging, it can actually be stored at room temperature for up to 7 days, which is really handy if, for instance, there's some delay if a patient doesn't show up for their appointment. You can always rebook them the next day. If there's any hiccups, you can actually hold on to the medication at room temperature and administer it anytime that week. If it's been left at room temperature for longer than 7 days, then it does have to be discarded. Coverage, and we'll likely talk a little bit about this at the case at the end of this trial, but coverage is available for this medication in the province of British Columbia. We recommend that anyone that the extended release buprenorphine is considered in any patient where the patient preference and your clinical judgment determine that they might benefit from a once monthly formulation rather than having to take sublingual tablets every day. If a decision is made collaboratively with a patient that they're interested in pursuing extended release buprenorphine, a special authority request must be submitted on their behalf. And those are available on the BC Special Authority website. This is an example of what the form looks like, and this can be downloaded and filled out. It's quite brief to fill it out, and it can be faxed in. Special authority is obtainable for this medication within 24 hours of faxing this form in. And in fact, it is on a list of medications where if this has been lost, or if there is a rush for any reason, you can actually phone special authority directly, and they're able to grant you approval over the phone, assuming you meet the criteria for special authority, which again are that a patient must be stable for 7 days on buprenorphine, on sublingual buprenorphine, and on a dose between 8 to 24 milligrams. So if they're and you do have to be quite specific in filling out this form as to exactly what dose they're on and exactly how long they've been on it, or it may come back to you for more questions. But as long as they meet those two criteria, it's quite straightforward to get the special authority request. Just to note, something that we've encountered in, for instance, a patient who may be coming from out of province, or may have been in hospital for some of the administration of the medication. If it's not visible on PharmaNet what medication they've been getting and what dose they've been on, you just have to write it in there and say, has been in hospital for the last 2 weeks, stable on a dose of 16 milligrams in hospital, dispensed by our formulary. Qualifies for a special authority request, and that should be sufficient to grant you the special authority. In general, I guess that just to say that the more information, the better when filling out those request forms. This is just a product insert, I think, that's available on the BCCSU website around information around product information and how to obtain that special authority if there are any questions. So practically speaking, again, this is a pretty straightforward medication to use. It's not complicated, but there's a number of discussion points to have with a patient when you're discussing whether or not they would be a good a candidate for this medication. So on anyone who's stable on buprenorphine, again, at a dose between 8 and 24 milligrams, I do talk to them about this being available. I want people to know about it. So discussing the potential benefits and risks of a transition with any patient who's stable on buprenorphine, I think it's worth exploring. If a decision is made that they feel they would prefer an injectable formulation, and that may be because of convenience, or because they don't like the act of taking the medication, or having to remember to take it, or even just the taste of the tablets themselves, then just recommend documenting that discussion, the pros and cons that were discussed, and the decision that ended up being come to in the medical record. At that point, you can fill out the special authority form and submit it. And once that coverage has been confirmed through PharmaCare, which again should be within 24 hours, you write a prescription for extended buprenorphine on a regular controlled prescription pad, the BC duplicates. And you just write, sublicated 300 milligram induction dose, and I usually write to be administered at our clinic, whatever your clinic name is, on whatever date it is, and send that into the pharmacy. In general, especially if this is not something that you do regularly, or if it's one of your first times, I would suggest phoning up your local pharmacy just to talk to them about the process and make sure that all your T's are crossed and your I's are dotted, and that the whole process will be rather seamless, and that they're able to order or stock this medication. I will defer to Mona's on the call, who can answer any questions around on the pharmacy side of things on how to obtain this medication. But pharmacists do have to contact Indivior directly to open an account with them in order to order the product. So they have to send a form in order to access the mechanism to order the product. And they will receive an email and username with their login information for the ordering account within 1 to 2 business days. So these are required in order to order the product on the pharmacy end. If a pharmacist would like to order the product, they complete a copy of the controlled substance ordering form, send it in, and Indivior will validate their license, and will finalize the order on this website listed here. Because there are a few logistical steps in actually administering this medication. It's recommended that prescribers and pharmacists, again, communicate with one another just to make sure you have a clear plan as to how this is going to go. So I recommend starting off this, giving yourself at least 1 to, if not 2 weeks in advance of the planned administration date to sort of jump through these hoops, especially if it's not something that's regularly stopped by your pharmacy. The pharmacist, again, has to go through these hoops to create an account, order the product. Usually, my understanding is the product is meant to arrive after ordering within 2 to 3 business days, although there have been some delays noted because of COVID, and in some cases it's taken up to a week. At that point, the product itself is picked up by a nurse or prescriber on behalf of the patient and taken to the clinic. So the product itself does not enter the patient's hands. It's picked up, and then the patient comes to the clinic at the assigned time, and that's where the administration is done. In accordance with CPBC requirements, even within the clinic, the buprenorphine must safely be safely and securely stored, and that cold chain management must be followed. Although again, you do have a fairly good buffer of 7 days once it's come up to room temperature. Although certainly wouldn't recommend administering it as soon as possible after warming, just to avoid any hiccups. Pharmacies are advised to stock only in the amount of buprenorphine extended release that they foresee will be needed in order to avoid overstocking. So the administration itself, there is a website that actually goes through this. So Indivior asks prescribers to go to, I think it's sublocadecertification.com, I believe, or is the website. And there is a sort of a mini training program that they ask prescribers to go through in order to familiarize themselves with the administration. So that's available online, and also all this information is in the product monograph, but it's quite straightforward. So the product can be administered by any physician, nurse practitioner, registered nurse, or RPN. It is, as mentioned, it's a subcutaneous injection in the abdominal region. So it's not to be injected anywhere other than in the 4 quadrants of the abdomen, and it is sub-Q. It's not IM, and it's definitely not IV. This bottom bullet here refers to this training program that the manufacturer would like all prescribers to complete. It's available on their website, but in BC, this certificate does not need to be provided to the pharmacist or pharmacy prior to prescribing. So really, it's something I recommend doing because it's about 15 minutes. And again, it's just going through the administration process. But once you get a approval number from Indivior, it's not actually required anywhere in our province. But we do recommend that providers receive the appropriate training before administering the injections. Annabelle has kindly put the link up there in the chat for those of you who would like to complete that. This is a helpful figure that was put together by one of our pharmacists just to help conceptualize what exactly this product is doing compared to our traditional sublingual buprenorphine. So it's a little bit, I'll walk you through it. So the y-axis here is our plasma concentration in nanograms per ml of buprenorphine, and the x-axis here is time. So you can see what we see here in red, for instance, which is quite prominent. That's the average peak and trough doses of buprenorphine in a patient who's maintained on a steady dose of 24 milligrams. So you can see the peak dose on 24 milligrams is just over 8 nanograms per ml, but it does drop to a trough of just around 2 nanograms per ml if it's administered once daily. So you end up with a mean dose, I think, of about, it's a 3.5 or so nanogram per ml, I believe, on 24 milligrams of sublingual buprenorphine. You can see in blue, you have an analogous figure there, or analogous tracing of peak and trough doses on 12 milligrams. And what you see in both the purple and green lines are examples of the average serum level obtained once you've achieved steady state on the injection. So with a 300 milligram injection, for instance, once you've achieved steady state, which does take somewhere in the range of about 6 injections to reach a real plateau, so about 6 months, but a lot of the heavy lifting is done with the first 2 injections. Once you achieve that steady state with the 300 milligram injection, you actually achieve a peak plasma concentration of around 10 nanograms per ml. It's just over 10 nanograms per ml. And that peak is achieved within about 24 hours of the administration itself. So it does achieve a very high dose in patients who you're maintaining on 300 milligrams. Over the next 28 days, that level does slowly go down, such that your trough on the 300 milligram dose is somewhere around 6 nanogram per ml. On 100 milligram steady state, which again is the recommended steady state in most patients, you can see your peak is around 5 nanogram per ml, so fairly consistent with somebody who's maintained on 24 milligrams of, with the average level of somebody who's maintained on 24 milligrams of Suboxone, with a trough going down to just over 2 nanogram per ml. So this is just a helpful figure to conceptualize what exactly is happening over those 28 days between your injections. This is a figure that I find really helpful, again, just to wrap my head around what's happening over time in patients who are on these medications. So this is from a paper that was just published at the very end of last year, which spends a lot of time discussing the pharmacokinetics of this product. And one of the questions that people often have is, what happens when you discontinue? So what happens to your serum levels when you stop the injections? And that is really helpfully described here. So you can see on the top, for instance, in somebody who's been induced with the 2 doses of 300 milligrams per 300 milligram injections, and then is now maintained on 100 milligram injections. You can see their sort of peaks and troughs over those first 40 weeks as they receive their serial injections. In this particular case, at 32 weeks, somebody has received their last injection and stopped at that time. So you can see they drop below the hash mark here. Is signifying 2 nanograms per ml, which is generally considered sort of the minimum therapeutic range for buprenorphine. So if they receive, after having about 6 injections of 100 nanograms per ml, they're expected to drop below that therapeutic range approximately 8 weeks after their last injection. But you can see that there's still detectable levels of buprenorphine for quite some time after that. In the bottom one, for somebody who's being maintained on 300 milligrams of dose, you can see it actually takes even longer. So if they were to receive the last injection at 32 weeks, it actually takes up to about 52 weeks for them to drop down below that therapeutic range of 2 nanograms per ml. There is serum levels sustained for quite some time. Even when you do discontinue this medication. That is not to say that they're going to be fine not taking any sublingual dosing over that time. If a decision was made by a patient for one reason or another to switch back to sublingual dosing, they may still have to restart that sooner than that, depending on their threshold for suppression of cravings. But it is still a helpful visualization of serum levels. So a number of considerations for specific populations for this medication. So in people who are pregnant, buprenorphine is not contraindicated in pregnancy, but the Atrogel delivery system, which again is the proprietary gel which the buprenorphine is housed in, which allows for this time release over 4 weeks. There's an ingredient in that which is contraindicated in pregnancy based on animal studies. And we have no data in humans. So it ends up coming down to a bit of a risk-benefit discussion. I wouldn't really recommend usually starting somebody on this medication during pregnancy, but if somebody's on it and they are and they do become pregnant, then it's really a risk-benefit discussion onto whether to take them off and risk potentially destabilizing them versus carry on with this medication, which may have at least theoretically could have some negative effects on the fetus. Similar breastfeeding, it's not indicated for use in breastfeeding, so it's again a risk-benefit discussion. And for people outside of the age range that was studied, that is less than 18 or over 65 years of age, it can still be used in those populations. But again, some caution should be taken. We do have quite a number of patients in Vancouver who are less than 18 who have been on this medication. but again, it is outside of the studied and indicated age range. So it's just something to discuss with your patient when you're talking about risks and benefits. And it needs to be noted in that special authority form if you are using it outside of those age ranges. So this is a really helpful paper. This is one of the last slides before we get into our case discussion, but a really helpful paper that just came out very recently that I thought that describes real life experiences with this medication in a low threshold bridge clinic in Boston. So up until this paper, all of the data had come from those industry sponsored trials. This was a paper that, at least to me, and I work at St. Paul's in a low threshold clinic or a low barrier clinic. This was a really helpful paper describing the experiences with 40 patients who were treated with this medication in a clinic in Boston. So out of these 40 patients, they did have 14 of them discontinue after 1 or 2 months. And there's a variety of reasons provided for discontinuation, but they retained a fairly significant number of patients over the duration of this study, which I believe was 6 months, or maybe it was a year, I can't recall now. Really interestingly, and I think that's something that's very, very practical, important to note, is that almost half of their patients required some supplemental sublingual buprenorphine at some point during their treatment. So as I've mentioned, it takes more than one dose to get up to a steady state. And especially in those early doses, as you're reaching that trough before your next injection, your serum levels really are dipping down very close to that 2 nanogram per ml threshold, which is in general considered that cutoff for a therapeutic dose. So it is not uncommon to have to supplement with some small doses of sublingual buprenorphine, especially around that trough area. I think some other patients that I've had have found it useful to have supplemental doses after the first injection when they're still getting used to not having to take the medication. I've had people who use 2 or 4 milligram sort of PRN doses early on as they still get used to the fact that they don't have to take a medication anymore. Or other people, for various reasons at various times in the treatment, have found the need to supplement their extended release formulation with sublingual buprenorphine. There's nothing automatic. There's nothing necessarily dangerous about doing so. In fact, as noted here, over half the patients required it at some point in time, as long as you're just being thoughtful and reasonable about how you're dosing it and what doses they're needing. And it's unlikely you can hear some people did require as much as 24 milligrams. In my experience, it's usually on the lower end that's required. Out of their 40 patients that they described here, a third of them still had some continued use of non-prescribed opioids, but many of those were still retained on treatment with this product.